You're listening to Medscape's In Discussion series on multiple sclerosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Ann Cross. Dr. Cross is a professor of neurology and holds the Manny and Rosalind Rosenthal Dr. John Trotter MS Chair in Neuroimmunology at Washington University and Barnes-Jewish Hospital in St. Louis, Missouri. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hello, I am Dr. Ann Cross, and I'm welcoming you to Medscape's In Discussion series on multiple sclerosis. Today, we'll be discussing the future of treatments for progressive MS. And I'm so happy to introduce my guest today, Dr. Robert Fox, who is a staff neurologist at the Mellon Center of MS at the Cleveland Clinic. He's also a professor of neurology at Cleveland Clinic Medical School, and he's vice chair for research for the Neurological Institute there at Cleveland Clinic. So welcome, Dr. Fox.
It's great to be here and join you, Ann.
I cannot think of anyone else in the world who's devoted their life more to progressive MS and trying to get effective treatments for it. But before we jump into that, I'd just like to ask you a little bit about you yourself and your background. What led you toward the MS field in particular?
Sure. This dates back to when I was an undergraduate and I chose a neuroscience major, mostly because it just sounded kind of neat and was different and the brain and seemed like a cool place to study. And I also took an immunology course as an undergraduate. This is in the late 1980s, so dating myself. And it was right when the immune system was being discovered and the basic building blocks of the immune system were being figured out and their interactions one to another and with organs and with diseases. When I got to medical school, I didn't find anything better than neurology. Having been a neuroscience major, kind of looked around, but nothing else really jazzed me up. And as I got into my neurology training, I didn't find anything more interesting than the immune system, which had kept my interest during medical school. And combining neurology and the immune system naturally led to multiple sclerosis. Now, by that point, it was the late 1990s, and we were just starting to develop therapies for relapsing MS. Although I was advised at the time, don't go into MS because it's a dead end field and we weren't going to make any progress there. But I ignored that occasional advice and still went into MS. And it's really ended up being a fascinating and tremendously successful field. We went from the early 1990s with absolutely no therapies for MS, nothing to slow down the course of the disease, to now we have over 20 FDA-approved therapies for MS. We have truly transformed the field in a little more than 30 years.
That's fascinating. And I would like to comment that these treatments that you mentioned are almost all for relapsing MS. We in the MS field, by the way, are so glad that you chose neurology and MS. You have contributed so much to the field, and I know the patients are happy about that too. And most recently, you were the lead author on a study called HERCULES of acalabrutinib, and that was in non-relapsing MS, and it arguably is the first really successful phase 3 trial for slowing progressive MS. Can you tell us about that, how you came to be involved with that?
Yes, I can. This taps into an area of the immune system called BTK inhibitors, or Bruton's tyrosine kinase. It's the name of a kinase that is present in B cells, also macrophages and their lineage, which include microglia within the brain. And they're involved in the maturation of these cells and in the continued cell survival of these cells. So stimulation of BTK is obligatory, is required for B cells to survive. So initially, when this was discovered, it was leveraged for treatment of B cell cancers. So if we could inhibit that, then perhaps we could program the B cell cancers to die. But they've also been leveraged in the last several years for autoimmune disorders that may involve B cells. And so it has been looked at in things like lupus and urticaria and multiple sclerosis, amongst other autoimmune diseases.
And what is special about BTK inhibitors, and why might they be effective against non-relapsing progressive MS?
What we've come to find is that the relapses, the episodes of neurologic dysfunction, blurry vision, numbness, and weakness that lasts for a couple weeks and then resolves, that seems to be driven predominantly by the peripheral immune system, the circulating immune system in the blood that then leaves the circulation for reasons we don't know and attacks the brain, the spinal cord, or the optic nerve. And all of our therapies seem to work by blocking that immune system's activation and entry into the central nervous system and attack of the brain and spinal cord tissues. Now, they all work in a different way, but they all seem to stop that peripherally driven action. What we've come to learn, though, is that they don't really impact progression very much, if at all. Now, if you stop attacking the brain will be better. If you stop attacking the spinal cord will be healthier. But it doesn't stop what's already set up, the processes that are already set up. And there's been a growing recognition that progressive MS is probably something that is going awry within the brain and spinal cord. Now, whether it's compartmentalized inflammation or accelerated neurodegeneration or some metabolic strain or mitochondrial exhaustion, no one really knows for sure exactly what is driving it, but it does seem to be something within the brain and spinal cord. And so it just makes sense that we probably need a therapy that gets into the brain and spinal cord in order to have an impact. Now, the compartmentalized inflammation can include B cells that are activated, can include microglia. Those are the brain resident macrophages as they get activated and cause inflammatory injury and damage. The idea is if we can get a drug into the brain and decrease that compartmentalized inflammation, we may have a positive impact. And that's exactly what the BTK inhibitor that was just published, tolebrutinib, does. It gets into the brain and we think downregulates both B cell activation and microglial activation, and thus is beneficial in decreasing that compartmentalized inflammation. Now, it also works on the periphery. So the original phase 2 trials in relapsing MS found a marked reduction in new lesions on MRI, about an 87% reduction in new lesions in the phase 2 trial. So the hope was that tolebrutinib and other BTK inhibitors would work both on the periphery, decreasing the influx of inflammatory cells attacking the brain and the spinal cord, and also working within the central nervous system to reduce that compartmentalized inflammation. That is what led to the 4 trials that were done, and one is still ongoing, 2 in relapsing MS, trying to reduce clinical relapses, episodes of neurologic dysfunction in relapsing MS patients. The 3rd trial was looking at secondary progressive MS, patients without relapses, so non-relapsing secondary progressive MS. And then the 4th, which is still ongoing, is a primary progressive trial. So patients who have a gradual little by little decline in the neurologic function from the very beginning. So the HERCULES, that 3rd trial, is the non-relapsing secondary progressive trial, which was set up to see if the drug tolebrutinib could slow the gradual little by little decline in neurologic function that our patients have. And indeed, that's what it found. It found a 31% risk reduction in the confirmed disability progression compared to a placebo.
That's fantastic. It's really, I think, going to set the stage for a new era. Because tolebrutinib and potentially other BTK inhibitors aren't extremely effective on relapsing MS, do you expect there to be combination therapies in the future?
I think so. Now, what was surprising was that the phase 3 relapsing trials did not show a reduction of annualized relapse. Now, it was compared to an active comparator, teriflunomide. So it's not that it didn't do anything, it just didn't do anything more than that active comparator, teriflunomide. What does that say? Well, it says that it probably doesn't work so much on that peripheral inflammation, but it does work on that little by little slowing. Now, again, it does do some on the periphery, just not as much as we had hoped and what we see with other therapies. So it raises the question of, will we need to combine a drug like tolebrutinib with another immune therapy? In some patients, they may not need more than the teriflunomide level of peripheral anti-inflammation effect, but other patients may need more robust peripherally acting anti-inflammatory therapy. And there will be interest in combining, but we don't have trials to know if it's effective in combination with another peripherally acting immune therapy, or the safety issues, because there are safety aspects with the BTK inhibitors, including tolebrutinib, that need to be balanced when we think about combining it with other therapies.
Do you anticipate any problems getting tolebrutinib through the FDA and approved?
It's hard to know at this point. It was only one trial that showed a slowing of disability in secondary progressive MS, but that relapsing trials, two of them, they did show a slowing of disability progression compared to teriflunomide, even though there was no benefit on the analyzed relapse rate compared to teriflunomide. So to me, that is the confirmatory studies that confirm the slowing of disability that the HERCULES secondary progressive trial showed. I think there is convincing evidence that it is effective. Now, there are some safety issues, and we should mention there's an increase in infections, particularly respiratory infections, in patients treated with tolebrutinib. A little bit increase in some bleeding complications that was seen in the relapsing trial. And most importantly, and most needing attention, is a risk of liver irritation, liver enzyme elevations. They can be very serious. And in fact, one patient from the secondary progressive MS trial died of complications following liver transplant. And the liver transplant was triggered by her treatment with tolebrutinib. So it is a serious issue that needs to be weighed in the risk benefit trade off. Now, the one good news about this is that all the cases of very severe elevation in liver enzyme occurred in the first 3 months of treatment. And we're hoping that weekly monitoring, which granted is a little burdensome, but only for 3 months, and probably after 3 months, it can be less frequent than weekly. We're hoping that weekly monitoring can identify patients who have this elevation in liver enzymes. And the treatment is very straightforward. We just tell patients, stop the drug. You don't have to give them a special antidote. There's no additional drug. You just say, stop taking that drug. And then we monitor to make sure the liver enzymes start coming down. And we tell them, don't take this drug again. So the management is very straightforward. We just have to have that vigilance.
Well, congratulations on such a successful study. And it's so exciting for our patients with non-relapsing secondary progressive MS too. So many are just waiting for something that will slow their disease.
It is. And we are waiting for the primary progressive trial results, which are expected to be announced by the end of 2025, and are hopeful that that will also show a benefit in slowing progression.
Clearly, you and I and many, many other people are really excited about the BTK inhibitors. What other things excite you in the world of progressive MS and treatment?
Well, there are other BTK inhibitors that are in development. And so before we leave the BTK inhibitors, there are other BTK inhibitors coming. There is fenebrutinib and remibrutinib and orelabrutinib. They're tongue twisters to say. They're in different stages of development. And some of them look to have the potential to be very exciting. So, two things to keep in mind. One, we already talked about how we want these drugs to also reduce the peripheral inflammation. And some of the drugs, like fenebrutinib, looks to decrease that peripheral inflammation and keep it down over the long term. Where tolobrutinib had an initial decrease in the phase 2 trial, but then that benefit kind of receded over time, the so-called tachyphylaxis, of biologic reequilibration of the body's systems. It may be that not all the BTK inhibitors do that. So fenebrutinib appears to keep the inflammation down, that peripheral inflammation down for the longer term. And so we'll have to see if that really does pan out in the continued open label extensions and whether other BTK inhibitors do that. The other aspect that we have to think about is the impact on progression probably requires, we're not sure of this, but probably requires entry into the brain. So crossing the blood-brain barrier at a concentration that is biologically relevant, meaning it actually has biologic activities. And that is a little bit unclear for some of the other BTK inhibitors. So we would like them to keep the peripheral inflammation down in the long term, and we would like them to cross the blood-brain barrier so they can have that impact that we saw with tolobrutinib.
This is really exciting times for progressive patients. What other things excite you in the world of treatment of progressive MS?
What excites me is one of the unfortunate lessons we learned from the tolobrutinib HERCULES trial, and that is that whole brain atrophy may not be as good as we had hoped it would be as a marker of pointing towards a potential therapy. So let me take a sidestep to relapsing MS. We have a very good pathway to identifying effective therapies for relapsing MS. We have some animal models that can test relapsing therapy. Basically, we immunize mice and rats with brain proteins, which cause an autoimmune response, and we can test our therapies to reduce that autoimmune response. We then go into humans and we measure the reduction of new lesions in very short, meaning 6 month, even as short as 3 month phase 2 trials, where we just say, are the number of new brain lesions reduced compared to some other comparator? And if it does, then we go to the phase 3 trial looking at relapses, episodes of neurologic dysfunction. And in every case, we've seen a reduction of new lesions in the phase 2 trial. We've seen a reduction in relapses in the long term, the exception being tolobrutinib because of the tachyphylaxis that I talked about. But up until that, we had identified a very nice model, preclinical animal models, and then a phase 2 outcome metric of looking at new lesions in MRI, and then looking at relapses in the phase 3 trial. In progressive MS, we are struggling. We don't know the right animal model, the right preclinical model that captures the pathology that is driving progressive MS. As I mentioned earlier, we don't know if it's compartmentalized inflammation, and even compartmentalized inflammation. There's lots of different types and different ways the brain can be inflamed. Or is it the metabolic dysfunction, mitochondrial exhaustion, and so on? So we don't have an animal model. We thought we had the phase 2 outcome metric, which was whole brain atrophy, that if we reduce whole brain atrophy, we can reduce disability progression. But what we found with tolobrutinib is we slowed disability progression, but we had no meaningful impact on whole brain atrophy. There may have been about a 10 or 12% slowing of whole brain atrophy, which was not statistically significant in the large 1,000-patient trial. Even if there really was a 10% slowing of brain atrophy, it wasn't meaningful in its magnitude and in the variability to be useful in a phase 2 outcome metric. So what we've learned is what we really don't know, and it's caused us to question, how do we identify potentially promising drugs for phase 3 using a short, small trial, the so-called phase 2 trials? We thought we had it in brain atrophy, but it turns out that that isn't what it needs to be. Now, I am convinced there is something in the brain we can measure that is being benefited by a drug like tolobrutinib and other things that we may find to be beneficial in progressive MS. And we just haven't figured out what that metric is. Is it cortical atrophy? Is it thalamic atrophy? Maybe it's not volumetric atrophy at all. Maybe it's something like magnetization transfer ratio. Maybe it's slowly expanding lesions. We don't know exactly what that metric is, but even just learning what it shouldn't be is a step forward. But it is a sobering lesson that if we had tested tolobrutinib in a phase 2 trial, we would have thrown it away because it didn't slow atrophy progression. But fortunately, we went right to the phase 3 trial and found it slows disability progression.
That is very interesting. And maybe now that finally there's a medication, a drug that slows progression clinically, we can go backwards and figure out, maybe using blood from patients in those studies, what things did change that correlated with the clinical improvement.
Yes, that is the hope. There should be something in the blood that we can measure. There should be something on the brain MRI that we can measure. Now, figuring out which tool, did we collect it during the phase 3 trial so we can identify it, or do we need to do additional studies, maybe PET studies using radioactive ligands? I mean, there are lots of different modalities to explore. But now that we have our positive control, the drug that seems to work, which is tolobrutinib, I think that will allow us to then start searching out to identify potentially beneficial metrics, whether they're fluid in the blood, maybe in the spinal fluid, hopefully in the blood, because that's much more convenient to collect than spinal fluid, or on the brain or spinal cord MRIs.
I mean, you've written a lot on neurofilament light chain, I guess, in the blood and the spinal fluid. What's your thoughts on that as far as a biomarker?
There was a lot of excitement around neurofilament light, and I was hopeful that that would be reflective of disability progression. It turns out it's not. There's a couple different things that complicate that. One is that new lesions on the MRI often, although not always, are associated with a big spike in neurofilament. So it adds a lot of noise to the progression measures. We're already able to measure that focal inflammation, either clinical relapses or new lesions in MRI. But many of those new lesions in MRI will spill out neurofilament into the spinal fluid and the blood. So it adds a lot of noise to make it difficult to find out what is actually slowing progression or helping the progressive aspects of the disease. We did a trial with ibudilast. Almost 10 years ago, we started that, and we found that ibudilast slowed progression of whole brain atrophy. It also slowed cortical atrophy and thalamic atrophy and slowly expanding lesions and several other imaging measures. But when we looked at neurofilament, it did not reduce neurofilament levels in the blood, and it did not reduce neurofilament levels in the spinal fluid. And that was one of the pieces of evidence that pointed away from neurofilament being a helpful measure, a treatment response metric for progressive MS. It's really a treatment response metric for relapsing MS. And because relapsing MS, that pathology, the new lesions, still happens in our progressive patients, it adds a lot of noise. Now, there is one situation where neurofilament is helpful, and that is in patients who are on a highly effective anti-inflammatory therapy, like a B-cell depleting therapy, and you wait 6 to 12 months, then their neurofilament level is predictive of their future progression and may be a treatment response biomarker, but we haven't looked at those studies yet. So I think applying a BTK inhibitor that slows progression to a group of patients who are on a highly effective anti-inflammatory therapy, that's one way to test whether neurofilament may be helpful. But again, that's getting into combination therapy, which we need to think about the safety and how we can effectively and safely combine those therapies.
Thank you so much for working on that study too, ibudilast, and bringing that forward. And I guess in that study, whole brain atrophy did seem to correlate or was positive.
Yes, it was. We did see a slowing of whole brain atrophy with ibudilast. We saw trends of slowing of disability, the clinical disability, although that was a phase 2 trial, so it was not powered to detect a slowing of disability progression. So it's not to say that whole brain atrophy never is a helpful metric. Of course, I'll add that we don't know that ibutalas certainly slows progression of disability, although it did look beneficial on many imaging measures and had some trends in the clinical measures. It never moved forward to a phase 3 trial, which is unfortunate. I think the company that owned the intellectual property, the IP, just was never able to find a partner to carry it forward, that drug forward into phase 3 trials. Phase 3 trials are just so expensive. They're $200, $300 million. And so you either need a big bankroll as your own company, or you need to find a partner who does have a big bankroll in order to move forward into those phase 3 trials. And unfortunately, ibutalas never found that partner to move forward into the large definitive phase 3 trial.
Well, I think we're coming to the end of our time here, but I again want to thank you, Dr. Robert Fox, for all the work you've done to help people with progressive MS and with relapsing MS in years past as well. But we know that progressive MS is a big problem now, and we don't have effective treatments quite yet, but maybe we will have one in the near future.
Indeed. I mean, we have transformed relapsing MS into a treatable condition. We haven't cured it yet, but within the first 2 or 3 therapies in almost all patients, we can convert relapsing MS into a treatable, controllable, manageable condition. And I am optimistic that in the coming years, we will do the same for progressive MS. It's clearly turned out to be a tougher nut to crack, and there may be different pathologies that are driving progressive MS. It may not be a single unified pathology, which may make it a bit more complicated. But I am optimistic that we will convert progressive MS into the successful story that we have converted relapsing MS.
Well, me too. Thank you so much, Dr. Fox, for being our guest on In Discussion, and keep up the great work.
Thanks for listening to Medscape's In Discussion Multiple Sclerosis podcast series with our host, Dr. Ann Cross. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on multiple sclerosis.